for many people to appreciate the lectures. So it's my pleasure to introduce Dr. Barbara Casadei, who is the winner of the 2022 Lucian Award. The award is courtesy of an endowment that was established at McGill University in the 70s. The first Lucian Award was given in 1978. It was an award established in honor of the two brothers of Olga Libovici. And McGill has had the privilege of hosting awardees over the years ever since then. Dr. Casadei did her training in medicine and cardiology at the University of Pavia and in Oxford. She did her DPhil at Oxford and was appointed a senior fellow of the British Heart Foundation, initially, subsequently promoted to professor and British Heart Foundation Chair of Cardiology. She became the head of myocardial the myocardial team in Oxford in 2014 and deputy head of the Division of Cardiovascular Medicine. Her specialization is in the area of atrial fibrillation, and she has published seminal work on molecular mechanisms underlying atrial fibrillation and heart failure, in particular with an interest in nitric oxide signaling in these pathologies. So it's a particular pleasure for me to invite her to the podium, but we're still having some PowerPoint issues. So it may take us another minute or so before we can actually get her connected. So we apologize for this delay. The title of our presentation is Fortune Sides with Those Who Dare. An intriguing and exciting title.
Can you do it? Yeah.
Fingers crossed, fingers crossed. Rounds 1A. Empty.
It's empty.
Yeah. There's nothing.
How is that possible?
Again, yeah, 0 kilobytes.
Yes. I'm really sorry. I don't understand.
I don't.
Yeah, really. Yeah.
Seems like we're making some progress, but we're not, we're still there.
Yes. In okay, there is no sound. There is an echo.
Monkey point.
Sorry.
Should be good now.
Is that okay?
Yeah.
Yeah. So, so the idea is that with the accepted idea is that it becomes more and more difficult as one's career progresses. But actually, as I said, Joe Goldstein has inverted this stairs this way by saying that actually the most difficult time for a researcher or for a young professional is to put your toe on those first very narrow steps, establish your reputation, after which you get known and things may actually get better. So if I have to project, for instance, my level of professional fulfillment over the years in an arbitrary scale from 0 to 25, I would have to admit that it has not been a linear process. And this is something you need to be ready for, because there will be huge swings. And interestingly, part of the times that are the most difficult are what I call the terrible 30s. And that is where you are contending both usually with a young family and your career. So, the career paths are definitely not linear. And you do have frequent drawbacks. And if I had to put the ages, around here, you could see that it starts to get better when you get older, something to look forward to. And in fact, I would say that the first 50 years are the hardest. So do hang in there and things do get better as long as you pass this very high attrition times of your 30s, where all the weight of the world is in your shoulders. So how do you get over this? You get over this by persistence. And persistent, I think, is probably the most important quality of a young professional. And as it says here, in the words of previous US presidents, nothing takes the place of persistent. Talent, education, none of this is sufficient. And there are many examples that I would give you to illustrate this. But say you want to be a clinical investigator and do what at least it was in my dreams when I was a young investigator, and that is identify a target and bring it all the way to a clinical trial. It takes a lot of time. So here is an example on how we first identify a NOx2 containing NADPH oxidases in human atrial myocytes and linked it with incident atrial fibrillation. That was the work of Young Min Kim, a Canadian student that did his PhD with me at the beginning of this century. And so from that, to get to a clinical trial where we looked at NOx2 inhibition using statin perioperative and the effect on postoperative complication and atrial fibrillation, it takes at least 13 or 15 years, 13 in this case, but in general, 15 years. So even though you have a long career in front of you, there are many of these cycles that you can have. And so you need to be persistent and not lose heart and choose carefully. And if you are interested in perioperative statins treatment and ROS in the reactive oxygen species in the pathogenesis of postoperative complication, there will be another grand round on May 15. So the other things that I would like to say to you is that you need to be open to the unexpected and very ready to spot an opportunity. So you would have guessed that I am interested in nitric oxide and reactive oxygen species. And when I started my career, there were a lot of very high visibility publication from Harvard in particular, that were identifying nitric oxide produced by the endothelial nitric oxide synthase as the origin of nitric oxide that regulated both beta-adrenergic responses and EC coupling in the myocardium. But actually, we tried to repeat this study, and it was true that nitric oxide had a role, but when we had properly the eNOS knockout mice, we didn't see any effect. And we did it by actually the effect, we saw it in the control group. And in the control group was the mice that were missing a neuronal isoform of nitric oxide synthase, which we also found was constitutively expressed in the myocardium, both at the level of the sarcolemma membrane and also in the sarcoplasmic reticulum. And so, and when we looked at that, we found that mice that were lacking this isoform had a slower relaxation, both in myocytes, as you can see here, and in vivo, as you can see here, and a slower reuptake of calcium, which was due to an effect mediated by nitric oxide on phospholamban phosphorylation. After that, this has became an important part of the activity of my laboratory because it kept popping up in various situations. So not only excitation contraction coupling, but also post-MI remodeling, flow independent coronary resistance and peripheral circulation, myocardial energetics and glucose uptake, and then there will be a talk about that this afternoon. So you can see here that young postdocs, actually not postdoc, graduate students who were involved in this work, all of whom got prizes, Young Investigator Award, and I'm incredibly keen for them to have a maximum visibility. So what you also need in your career is someone that looks after you and shows your face around a meeting, making sure that they know who you are. So the one of the key interests, as has been said before, of my lab is atrial fibrillation. And like most investigators, I was very much interested in the atrial fibrillation induced remodeling that then begets atrial fibrillation. The concept comes from the 90s and comes from Maurice Alessi's lab in Maastricht. And what they found was that if you induce atrial fibrillation with burst pacing in an animal model, in this case a goat, after a few days, the atrial fibrillation would sustain itself. You don't need to pace anymore because of the remodeling that occur in the atrial myocardium. And the first stage of this remodeling is electrical and essentially consists in a reduction of action potential duration that then favors functional reentry and the maintenance of the arrhythmia. So although this has been shown, essentially repeated in every model of atrial fibrillation, it is quite difficult to know. In fact, we didn't quite know why you had this remodeling. Why is this happening? And so again, going back to our nitric oxide and reactive oxygen species, we had some initial data that suggested that nitric oxide and reactive oxygen species might actually be involved in this process. So how do we work? I mean, here is an idea of how my lab is organized. We generally start from human tissue, which we take from biopsies and samples that we take from patients undergoing cardiac surgery. From this, we isolate myocyte fibroblasts. We do omics, microRNA, RNA-seq, and all of that. And once we find a mechanism of the idea of that might be relevant to the pathology we are interested in, then we would normally, or at least in the past, have answered the question, is this sufficient to create a phenotype, by making a genetically modified mouse, which we can phenotype very well these days. Then if that proves to be the case, we will move to a large animal model and eventually back in humans with imaging studies, as well as large cohort UK Biobank, which I know you're also using, and clinical trials. So, you know, if you present something like that as your ambition to your supervisor, they are likely to say, oh my gosh, you're all over the place. You know, you need to focus. And in fact, there is a certain tendency to actually say that. And that might be right for some people. It wasn't right for me. And one of the reasons I'm here with you today is because I never listened to my mentors. And so I would suggest you actually try to be ambitious, and also beware of mentors who are encouraging you somehow to underachieve. And that is particularly true if you are a woman or someone that doesn't fit the prevailing image of who is going to be successful in the future. So, you know, is something that you need to take into consideration. So, using this kind of big circles, what is it that we found? We were interested. We had some preliminary data indicating that very early after the induction of atrial fibrillation, you had a dramatic reduction in the in nitric oxide production from the atrial myocardium. And so the question is, an animal model, you know exactly when you start atrial fibrillation, and so you know whether that is going to be just an early phenomenon, whether it's going to be sustained in time, and all of that. And so for that, we looked at goats, you know, both in sinus rhythm and after 2 weeks and 6 months of atrial fibrillation. And as you can see here, there is quite a dramatic reduction in the amount of nitric oxide that is produced by both the right and the left atrium of this animal already after 2 weeks, but also again after 6 months. The next question is, of course, is this also happening in humans? And so we looked at specimens from 347 patients, of whom 73 had persistent atrial fibrillation, and we could reproduce the same result, and that is a profound reduction in nitric oxide production. And you think, well, why should this happen? I mean, what is the source of this nitric oxide? And so when we did various Western blotting and PCRs, etc., and this is in isolated atrial myocytes from patients in sinus rhythm and atrial fibrillation, we didn't see any difference in inducible isoform of NOS or in the endothelial isoform of NOS, but we had more or less a near disappearance of our famous neuronal nitric oxide synthase here, down to 0. And again, why should this happen? What is it that influences the stability of the nNOS protein? And here is the other message, and that is, I know that you may be training for your subspecialty and really resenting doing your general medicine or other or looking at other subspecialty because you want to focus on your one. Actually, it's quite useful to look at what other people do and how they do it and what they have discovered. And that particularly oncology, neuroscience, there is a lot that one can learn there if you want to be a researcher. And so from the word of from the world of Duchenne muscular dystrophy, we know that nNOS is tied to dystrophin, and that is what it tethered the nNOS to the sarcolemma membrane. And in the absence of dystrophin, the nNOS in the cytosol gets rapidly degraded and disappears. So could it be that atrial fibrillation is a dystrophinopathy of the atrium? Do we also see a reduction in dystrophin? And indeed we did. You know, when we looked at dystrophin, we didn't see any difference in the mRNA, but we saw a reduction, a significant reduction of dystrophin in myocytes from patients, atrial myocytes from patients in atrial fibrillation. However, we do have a 60% reduction in dystrophin and a 95% reduction in nNOS. And so there might be some other mechanisms. And so, but the key question is, does it matter? And if you look at action potential duration here, you see that if you inhibit the neuronal nitric oxide synthase with S-methylthiocitrulline here, in this myocyte, you see a reduction in the action potential duration, but you do not see that in the presence of atrial fibrillation. So there is a phenotype here and then if you ask your question, is this sufficient? And you look at the nNOS knockout mouse here, you see that atrial fibrillation inducibility is enhanced in this mice in the absence of a structural remodeling of the heart. So it's all electrical. So again, you know, why should that be? And you know, you can spend a lot of time because there are many mechanisms that can lead you to the reduction of a protein. And after we tried a few, we homed in microRNA. And as you know, the microRNA can both inhibit reduce the amount of protein through translational repression of the RNA or by accelerating the degradation of the messenger RNA. And by doing our screening, we found this microRNA 31, again, going back to the Duchenne muscular dystrophy world. It had already been demonstrated by some investigators that microRNA 31 is actually inhibiting the translation of dystrophin. So to cut a very long story short, what we then found was that in human atrial fibrillation, there was an upregulation of microRNA 31, then bound to the 3' UTR region of dystrophin and inhibits its translation, exactly as it's been shown in the skeletal muscle. As a result of that, part of the neuronal nitric oxide synthase also went into the cytosol where it was degraded. But the other point was that microRNA 31, you know, as you know, microRNA are pleiotropic, also bound to the 3' UTR region of nNOS and accelerates, in this case, is decay. So the final result is that you have a reduction in massive reduction in nitric oxide production in defibrillating myocardium that has, amongst other effects, also an effect on repolarizing potassium currents and reducing action potential duration at the level of, you know, contributing to the mechanism by which atrial fibrillation begets atrial fibrillation. But then again, you know, you always have to keep questioning. So, you know, I've always been a bit skeptical, although like everybody else, I have sinned in this direction, that it was all down to, whether it was all down to atrial fibrillation-induced remodeling. And that is the way we think. If we take a healthy animal, and then we put a trigger like burst spacing, induce atrial fibrillation, and look downstream, it is not unusual that we come to the thinking that atrial fibrillation is the source of all evils here. right? Because otherwise this animal would be perfectly fine. But is that what happens in humans? And I'm trying to advance this slide. Yeah. Okay, yeah, all right. So is that what actually happens in humans? And I would say most of the time is not. Is not because in humans atrial fibrillation is the manifestation of sorry, I have something of them, and the manifestation of environmental and genetic factors over time that are different in different patients, producing different types of atrial substrates that may underpin both atrial fibrillation and stroke risk of other complications. So we have different heterogeneous group of diseases that go under the name of atrial fibrillation. And because of that, we could also have different types or degrees of atrial fibrillation-induced remodeling. So, you know, if one takes this view, then one could start with hypothesis saying, well, maybe atrial fibrillation is the biomarker of a cardiomyopathy that causes both the arrhythmia and maybe the increase in stroke risk and heart failure risk, right? If that is the case, what is the evidence? So there is something here. I close, yeah. So going back to our circle and focusing now on imaging, I give you some ideas of how one could tackle this. So, you know, the question is, if there is a cardiomyopathy, how are we going to know whether it's the chicken or the egg? Which one comes first, you know, the atrial fibrillation or the cardiomyopathy? So, you know, we could have a model by which atrial fibrillation is the cause of left ventricular dysfunction. And that is very much what, you know, in most cases, our reasoning is around this. And as a result of that, if we ablate someone and recover sinus rhythm, the left ventricular dysfunction should improve dramatically. However, if there is an association between a cardiomyopathic state and atrial fibrillation, then if we recover sinus rhythm as shown here, we are still left with the background left ventricular dysfunction or abnormality, which then will favor the recurrence of atrial fibrillation as we see in the clinical arena. So here is a study for which, and I go through this quite quickly, we recruited patients with atrial fibrillation and no other comorbidity that we could, so it's as close as we could be to the word that we must not say, which is lone atrial fibrillation. And they were all waiting for catheter ablation. 50% of them had paroxysmal atrial fibrillation. And we looked at them and also against a matched group in sinus rhythm. And we used advanced MR imaging to phenotype the possible cardiomyopathic background. They all have, you know, they did not have a cardiomyopathy as such. So we did CNET, tissue characterization, 31 phosphorus magnetic resonance spectroscopy to look at myocardial energetics and myocardial perfusion with adenosine stress. So we studied them before the ablation, immediately after, early after ablation, to see the effect of sinus rhythm on left ventricular function and properties, and then after 7 months or so, where we should have seen an element of remodeling of the, if there was such a thing as a positive remodeling after recovering sinus rhythm. But as you know, people say AF begets AF, but sinus rhythm does not seem to beget sinus rhythm. So, and we looked at all of these parameters here, and we did the same in our control. So this is what you would expect, and that is that patients with atrial fibrillation have a slightly reduced left ventricular ejection fraction compared with matched controls, but same, is still within, for our core lab at least, within the normal range, and the same is seen with the left circumferential strain, essentially saying is associated with some degree of left ventricular dysfunction. And similarly, when we look at the magnetic resonance spectroscopy, we see a similar, also a reduction, a lower phosphocreatine to ATP ratio in patients with lone atrial fibrillation compared to the controls. But the question is, would this recover after recovery of sinus rhythm? You know that in patients with atrial fibrillation can come to A&E with raised troponin and an altered ECG, suggesting that there might be a level of problems with the microcirculation when there is no obvious obstructive coronary artery disease. And that also happened with our patients with lone AF. And that is, they all had a lower baseline myocardial blood flow, and also stressed myocardial blood flow was lower. So what does all of this recover? And you can see here, for the left ventricular ejection fraction, that there is a slight improvement with the recovery of sinus rhythm that really mostly occur early post-ablation. But even then, our final ejection fraction is still lower than that of control. The same happens for the phosphocreatine ATP ratio, and that is, in fact, it's not the same. It doesn't change at all with the recovery of sinus rhythm, even in association with a slightly better left ventricular ejection fraction. So, and the same is the case for the stress and basal myocardial blood flow. So if you have something like this, then you can conclude that lone atrial fibrillation has a mildly impaired left ventricular function, reduced myocardial perfusion, and energetics, all of which fail to normalize after successful ablation. And here you would then come reasonably to the conclusion that they may actually precede atrial fibrillation and constitute the substrate that supports the arrhythmia rather than being a consequence of atrial fibrillation. But people don't tend to believe these kind of things. They always would find, the diehard, the remodeling people would say, well, maybe there were irreversible changes and you haven't waited long enough and all of that. And so you are left with that chicken and egg problem. And really the only way you can unravel this is through genetics. The genetics always come first, of course, and now we have enormous GWAS meta-analyses that allow us to look at this heterogeneous nature of atrial fibrillation. And in fact, if you look at all the genes that have been identified in these large GWASs, you can divide them largely in three large groups. Those that belong to the muscle function and integrity world, the ion channel function, and developmental events. And if you then look at this characteristic in patients, you find really interesting differences, potential for personalized treatment, and differences in the stroke risk in these three groups. And I would elaborate further that during the cardiovascular research day. So finally, I would like to conclude by talking about the politics of health. So why it is important to engage with that? I mean, health is a political factor. You know, I mean, you may have, like it's happened in the UK, where I come from, people under, you know, a group of politicians that would, you know, really underfund the national health system, increase the poverty divide, with enormous consequences on the health, the public health of the nation, and then blame you, the doctor, for not doing your job properly, right? So you will be having this kind of pressure. And I would say, if you do, engage and use your skills to make a difference and defend your position, and make a difference not just to individual patients, but at scale. An example of that, during COVID, a classic, you know, as you know, COVID started in Europe, in Italy, in Milan, in the Milan region. And here, my colleague told me over a coffee, you know, since COVID started, we don't see patients coming in with an acute coronary syndrome. And she's an interventional cardiologist. And, you know, with that, you know, COVID was just coming in the UK. I thought we must look at the central NHS healthcare data, the very first one, to actually look near real time whether this was happening in the UK and why it was happening. And here is what you find, you know, what we found. So we found that, you know, if this is the average of the acute coronary syndrome of patients admitted in the year before, and at the same time of the year, you could see this really great reduction in the number of cases in the UK as well. And people thought this was a good thing, because it was because the lockdown decreased stress, and maybe generally there were less cases, but actually they start to decrease at the time of the first COVID death is reported in the UK. And there has been a protect the NHS campaign from the government, that is, don't come to the hospital because we're busy, right? And the lockdown is this dotted line here. So you can see that we were already decreasing, you know, having less patients like that well before lockdown. And then we started a campaign at that time with the British Heart Foundation and the British Cardiovascular Society. You know, really, they went all the way to the government here by saying, you know, actually, protect the NHS is only valid, but if you have a chest pain, come to the hospital. And this caused quite a significant rebound on the cases. Just at the time here, the infection was raging in the UK, but nevertheless, patients will still come, started to come back to the hospital with an acute coronary syndrome. And at that time, I was president of the European Society of Cardiology, so I extended the campaign to Europe, and you could see that it went throughout the nation, and the data are very similar. These are the data for Italy, for instance, very similar to here. And if you look at the statistics in Italy, you could see that almost as many patients died at the time in excess died at the time of COVID than those that died because of COVID as a result of you know, the stroke, the ACS, didn't come to hospital, the cancer care, etc. So why is this important? It is important because it was done in real time. Yesterday on the Financial Times, there was an article saying, oh, a lot of people, extra people died during COVID. They shouldn't have done, you know. In fact, the campaign was, we need to save those that we can, the lives that we know how to save, right? But what is the point of knowing now? You know, the important point here was to know at this particular point. So engage and lobby for the use of health data, because they really can make a huge difference to what is the learning health system everybody talks about, but very few people actually practice it. So I want to finish on a light note. So you can see this picture. It reminds me of when I was, my daughter was little, And we used to go for a walk in the park, and there would be young couple kissing like that. And my daughter would say, "Oh, yuck, that is really disgusting." And I would say, "Well, you know, Isabella, you know, with time, you may find that you change your mind." And this is my message to you. You know, you have to try. You have to try research. You have to try to engage as a professional in advancing your field of your subspecialty, and you know, the importance of being a clinical investigators cannot be underestimated. And you will find that at the right time, with the right environment and with the right people, it would be a very good experience. So with that, I thank you very much for your attention. And here is the group of people that have contributed to the work. You can see very cosmopolitan. And thank you very much for your attention, and apologies again for the technical side of my computer that didn't work.
Thank you very much, Dr. Casadei. That was really a spectacular talk. And we did subject you to the usual stress test of having technical issues at the beginning. But I'm delighted that you came through it all without too much damage. So we have an opportunity for some questions. You're okay where you are, I think. So, waiting for questions. Yes.
So just on the last point, Lucian scientists being advocates and trying to influence politics. If COVID-31 happens, what are we going to do to prevent excess cardiovascular mortality in 2031? What structural changes we need to make to our healthcare systems, appreciating that the healthcare systems are different, but also have strengths and ways.
Well, the problem is resilience. So if you are at the minimal possible funding of your health system, the moment that something else happens, the whole thing crumbles because there isn't a resilience built in the system. So that has been the main problem, because that's what has been the password of the people in charge of administrating hospital, etc., you know, to actually cut it as close as possible to the line. So then an emergency happens, and so that's would be the first thing. The second thing is also the the awareness. For instance, you know, we had COVID patients close to cardiac patients at the end who had problems in segregating the hospital. You know, that was wrong. Because a lot of people said, "I'm not going to hospital now. I already have, you know, I'm already sick enough. I don't want to go there again," and had the heart attack and the stroke at home. I mean, I didn't think that was possible, but it happened. And so that is another thing. We need to have a model by which we can segregate, you know, we know what to do, you know, in terms of organizing the various sections of our hospital in a way that they can be segregated. And I have also, you know, a long list of other things, but I would say these two would have made a big difference. And also the unintended consequences of good intentions. You know, people who say, "Don't come to hospital," and then people take it literally, particularly in the UK, and then you see things like that. But, you know, you need to have access to the data. And not in 2 years' time, you know, when it happens, and that will make a difference, because then you know where you're failing and where you're succeeding.
Yeah, I was going to ask a question about dystrophin. So do patients with muscular dystrophy inevitably end up with atrial fibrillation?
This is a super question, and the answer is no. Because we have recently looked at that, and in the atrium the atrial tissue of large animal and small animal models of atrial fibrillation, there is no reduction in nitric oxide production. So there is an increased phosphorylation of other isoforms that produced and maintain the level of nitric oxide. And as a result, you don't see that reduction that you see in atrial fibrillation. So it's different.
Very good, thank you. Dr.
Thank
Giannetti.
you, that wonderful lecture, very interesting. We often use the term tachycardia-induced cardiomyopathy.
That's right.
And most of the time it's AFib, but it's not always AFib.
Yes.
So if you teased out how much is the sort of AFib pathology versus the tachycardia, somebody, let's say, who's long-standing SVT, can you just, because obviously once you treat the tachycardia, the cardiomyopathy usually resolves and improves. So
Yes.
how do you tease those out?
Yeah, I mean, there are plenty of examples. I mean, the rate control is the cornerstone of the management of atrial fibrillation, right? For several patients, that is sufficient. Clearly, if you have a ventricle that goes at 200 beats per minute, you are going to have problems. But none of the patients from the study that I have shown actually had tachycardia. We monitored them, we looked at them during exercise, but you still have that kind of, you could call it subclinical cardiomyopathic phenotype, even in the absence of that. There is no question that one has to prevent the tachycardia-induced cardiomyopathy, and most of the time, either through ablation or pace and ablate or just drug. It's possible. That's one of the things that we can do. But then you're not solving the whole problem. Yeah.
Thank you very much. So I don't see any questions in the chat. Yes, one more question.
So if I understand, you showed us the data about the lone AFib, so-called lone AFib, but there's no such thing as really lone AFib.
Yeah.
So when you talk about anticoagulation, obviously we usually look for this concept of CHAD that you're going to have one associated finding. Is it, should we be looking for underlying disease and using that as a reason to start anticoagulation? In other words, because there's no such thing as you're showing just as lone AFib. Well,
that is a big question. At the moment, we are using the GWAS score, and we are guiding the anticoagulation on that. We have data, for instance, if you believe that the thrombus in the left atrial appendage happens because there is stasis or abnormal left atrial flow, then we can see that also in high-risk patients that do not have atrial fibrillation. So that there could be, looking at flow, you could extend the indication for anticoagulation to other patients. Equally, we know that if you do not have, if you have atrial fibrillation and you're young and your GWAS is 0, then clearly this abnormality of the flow on its own is not sufficient to cause a thrombus. So I think that there is a lot of room for improvement in the stratification of stroke risk, and therefore also the allocation of anticoagulation. And then there is this big uncertainty of burden. I mean, at the moment, 30 seconds of atrial fibrillation is atrial fibrillation. I don't believe that 30 seconds of atrial fibrillation is like being on atrial fibrillation all the time, as far as your thrombotic risk is concerned, but we don't know.
Thank you.
Thank you very much. So thank you. This was an excellent session. We had almost 100 people in attendance, which, I'm glad they didn't show up to this room for the occasion. So,
shame.
So thank you very much, Dr. Casadei, and thank the audience for being with us.
Thank you. Thank you.
Oh boy.